Thank you. We might go on to our second presentation and we'll come back to discussion at the end. So the next speaker is Dr. Paul Nambala, who's a clinical officer in the community clinical service at Kazungulal Community Health Centre. I hope the pronunciation is vaguely correct, Paul. And he's going to present a cohort study, urgent need to strengthen active tracing of loss to follow-up individuals, and he's presenting on behalf of colleagues from Lusaka, Zambia, and the Japanese Associated Health Program. Thank you, Paul.
Thank you so much. Good morning. Presenting urgent need to strengthen active tracing of loss to follow-up cases. This is a prospective cohort study of newly diagnosed HIV clients in rural districts in Zambia. On the background, HIV in Zambia, Zambia has a population of 13.2 million people as at 2010 census. The new infection rates in 2011 were 0.96% among males, 1.25% among females. The HIV prevalence in Zambia is currently at 14.3%, 2007 ZDHC. So we looked at the rural areas and urban areas comparison. In the rural areas, 10.3% is a prevalence, and in urban setting, 19.7%. So Kazungula and Kalomo district, these are districts that are running in the southwest of Lusaka, which is the capital city of Zambia. We share borders with Zimbabwe, Namibia, Botswana, by the Zambezi River that runs across, and this river flows into the Victoria Falls. You may be wondering probably why we took up this kind of study. We are at the border area. The total population is just slightly below 400,000 of the two districts, and we have an area per square kilometer of 30,000. The mainstay is agriculture and animal husbandry with a few industry. HIV in Kazungula and Kalomo. We dubbed this the Kaka cohort study, Kazungula and Kalomo. The adult HIV prevalence rate for the two districts is at 13.4%, and the ART services started in a few selected health facilities in 2005 and have been scaling up. You may want to know that free ARVs have been given in Zambia since 2004. So a number of HIV-infected adults on ARVs in the two districts is currently at 8,200. We have two objectives for this study. One, to assess the retention among HIV testing, care, and treatment. Two, to evaluate active tracing for loss to follow-up cases in rural districts in Zambia. Methods. Like I said, it's a prospective cohort study which is still going on, but we had to do a kind of evaluation at 12 months. Newly diagnosed HIV clients from April 2012, since the study began, to March 2013 in 8 health facilities in Kazungula and Kalomo has been enrolled. 1 district hospital and 7 rural health centers. The data have been collected through patients' client records and during interviews, like when we find defaulters, we want to interview and find out why they were not coming. The assessment was done at June 2013. The retention rates were estimated by Kaplan-Meier method. Results, Table 1, baseline characteristics of enrolled cases. The study side, like I said, we had 1 district hospital and 7 rural health centers. And you notice that a number of patients came from the hospital, 49.1%. Then the 7 rural health centers gave 50.1%. HIV test entry points, these are departments that are supplying the clients, we have OPD and inpatient department, which had 30.8%. From voluntary counseling and testing, which we call VCT, we had 38.9%. Antenatal clinics, stroke MCH, we had 12%. From TB, we had 1.5%, and others, many, maybe from other partners, non-government organizations that were coming in as referrals, we had 16.8%. At eligibility at baseline, eligible clients were 414, translating to 63.3%, and those that were still not eligible, which we called pre-AT, were at 36.7%. You may want to know that the cutoff point for starting of ARVs in Zambia, that time we were at 350 CD4, 350 cells. Baseline characteristics of adult cases, this continues on gender. Males, 41.1%, females, 58.9%. Again, you'll notice that females are a bit on the higher side. The World Health Organization staging, in Zambia, stage 3 and stage 4, automatically we do start them on ARVs. Stage 1 and 2, we needed to consider. So discount couples, we had 8.4%. On the age, median was 33. Then the median CD4 cell, 286. Results continue. HIV positive, the total number of cases which we got from this department as supplied were 822. Then these were referred for HIV care and probably treatment. You will notice that there is a gap between 822, the only ones that were enrolled were 654, meaning we lost about 168 clients who never reached the care point. Then from OPD, we had the largest number of clients coming, 87.4%, that were put in care. VCT, 83.1%. From other departments, 58.7%. From the HIV care point, those that went to pre-AT that were not eligible by that time were 240. Then those that were commenced on AT were 414. And like I said in the beginning, we evaluated these clients at 12 months to see what were the trends, what was happening. Results continue. At 12 months retention, those who were on AT, from the beginning to the time we did the evaluation, we had 75.4% that were still on our program. Pre-AT, those were still coming to be assessed whether they have become eligible, were also 75.9%. Results continue. Lost to follow-up at 12 months, the number was 139. Then we determined those that had phones, those that didn't have phone, being a remote area. Those that had phones were 53 out of 139, which is 38.1%. And those who didn't have phones, during the initial registration, they couldn't avail numbers, were 86 out of 139, 61.9%. We followed up those that had phones. Trying to call them, reachable clients were 17, not reachable 14, and where the phone could say invalid or long numbers were 22. We continued on those that were reachable clients. We managed to have 3 return to the original facility where they had initially registered. Self-transferred out were 4. During the talks we had on the phones, we found that they had gone to other facilities. And despite talking to 10 of them, they never came for care. Now, the point of those who had no phones, we tried to look at them. The numbers are translated to 122 out of 139, which was 87.8%. And these we thought they needed physical follow-ups. Discussions. The reason for many lost to follow-up cases were we thought maybe long distances to access art services, bad road conditions, especially like in the rainy seasons, not enough attention by staff and treatment supporters, still have some stigma among HIV clients, and we had many seasonal migrants, like those who are fishermen. They would move from one side to another depending on the season that came by. The linkage between diagnosis and care should be strengthened, and there's need to conduct adequate counseling soon after HIV diagnosis so that we minimize the lost clients to go to the HIV care site or treatment. Tracing loss to follow-up case by phone is not feasible in rural areas of Zambia because, one, most clients may not have mobile phones. Some clients give wrong phone numbers and addresses, and poor accessibility of phone networks in the rural areas. Adherence counseling at every visit, we thought at every opportune visit you come across a patient, client, we could do adherence counseling, and maybe physical tracing could also be strengthened. The need to consider how to motivate treatment supporters has been a bone issue and a challenge. Conclusions: despite having successfully scaled up HIV services to many rural health facilities in Zambia, we still have a big gap, big number of lost to follow-up cases. Therefore, there is urgent need to strengthen active tracing of lost to follow-up cases. I would like to acknowledge the people involved in the study, our patients, our treatment supporters, the district medical offices, Jai Kashima Project, NCGM in Japan, the Minister of Community Development, Mother and Child in Zambia, and the Minister of Health in Zambia. Thank you so much.
Would like to call for people to go to the microphone and ask Dr. Dambala any questions that are arising. In the meantime, could I ask, in terms of active outreach, who do you think would be most appropriate in your setting to be doing that, and how would you engage that?
Okay, on that one, I think the basic would be the treatment supporters. The healthcare workers that are trained are very limited and probably could not want to be posted to the remote areas of the country. So training the treatment supporters in a way, I think this could help us so much. Thank you.
Hi. John Gill from Canada. Very nice work. Many of the reasons that your patients are giving why they've gone lost to follow-up actually is similar to what we're seeing in a very developed part of Canada. Often the argument about distance to travel has been proposed in my area, and when we provided a health caregiver 20 yards away from the individual, they still don't engage to care, which suspect there's often, they're using it as a reason, another reason, there's something underlying it. Do you believe the reasons that your patients are giving you, are they legitimate, or do you think they're really not engaged in care as well as you and I would like?
I could say yes and no. No, in a sense that being a very remote areas, even the health facilities are quite limited in our areas. And the service of art is not usual in those clinics. They're quite small clinics and maybe not conducive to stock drugs and other things. So there's a mobile team that may go to that area, and not all health facilities are catered by the mobile clinics. So usually it becomes a bit of a problem. Yeah.
There's a question up here at this microphone.
Thank you. I'm Jill Sanders, working for Baylor College of Medicine in Lesotho. Thank you for the presentation, but I was very surprised to see that your rate of follow-up was the same in pre-ART and ART patients. Almost all programs struggle to retain pre-ART patients. So I was wondering if you had any insight as to why those were the same. Thank you.
The answer to that one might be, if you remember on my slides, I think that was from the entry point of HIV, the cases that were taken up. Then initially I explained to say Zambia, we had the baseline of 360 CD4 count for start of ART. So those who were below 360, I think those are the ones that went to ART. Those that were above 360 were deferred to some other day. And those that were deferred were the ones which we put in pre-ART care, not on treatment. So on pre-ART care, those are the ones that we found that at 12 months evaluation, we still had 75.9, and those on ART that were actually on treatment, they were 75.6%, if I remember well.
We might have one last question from that microphone.
My name is Nick Madeline, now working in Melbourne, but recently been working in Vietnam on the Cascade. As we look at targets like 90-90-90, the finer points of getting the last few patients who've not engaged to care back into care are going to become increasingly important. It was interesting, I thought, as you followed patients up by phone, that those that you're able to contact, on the whole, didn't come back to care, which indicates that really active follow-up of any variety may not be all that effective. It's clearly going to be prevention of loss to follow-up. That's going to be the issue. So I really wondered whether you, and really I guess it follows up on the first question, to what extent do you think that you can keep people in care and then prevent issues like distance, finances, engagement, non-engagement, becoming re-engagement barriers? So I really wanted to talk to you about the prevention of loss to follow-up.
I don't know if I got you on the question. Maybe you can repeat?
It seems that once patients are lost to follow-up, they've either selected themselves or they've made a choice. It's difficult to get them back into care. Do you have any ideas about how we prevent patients being lost to follow-up in the first place?
Okay, the first one could be adherence. I think every opportune moment we come across these patients, we try to explain what is the benefit for them being on ART, what is the benefit for them keep coming for care. Then the other point probably I mentioned was that we're at a border, and being a free HIV giving nation at that time, I think we had many people coming into to get the drugs and the like, but I think stabilized. I think most of those people might have got out of the country. So probably that also contributes. But I think the best we could do out of that is to try to go on the ground and see who is indigenous, who is supposed to continue on the care.
Thank you.
Great.
Thank you.
We want to thank you very much, Dr. Mbala, and we're going to move on
Thank you
to our
so
next
much.
presentation.